Dear students and colleagues, the topic of presentation is hemochromatosis, and it's one of the autosomal recessive disease that result in systemic iron overload due to deficiency in hepcidin, is an iron regulatory protein, and the deposition of excess iron is into parenchymal cells of liver, and it leads to dysfunction of hepatocytes and clinical manifestation of hepatitis and in terminal stage liver cirrhosis. It's a disease which present with multi-organ damage, and such organs as liver, pancreas, joint, heart, skin, pituitary gland affect in hemochromatosis. Hereditary hemochromatosis should be considered in differential diagnosed patient who has elevated liver enzymes. It's LT and ST and abnormal iron study results. Individual with a hereditary hemochromatosis has increased risk of hepatocellular carcinoma and cancer of rectum and breast. That's why diagnosis in time is very important for prophylaxis these complications. We differentiate several subtypes of hereditary hemochromatosis, and very common worldwide is type 1A. Hereditary hemochromatosis is a homozygous type which present abnormal HFE gene with the mutation C282Y, is the autosomal recessive mutation, and a patient with this type of hemochromatosis has a clinics of joint disease, skin pigmentation, diabetes, endocrine dysfunction, cardiomyopathy and hypogonadism. There are another type of mutation like HFE gene H63G autosomal recessive mutation is a type 1B compound heterozygous mutation. Type 1C hemochromatosis with mutation HFE gene S65C. Type 2, type 3 and type 4 they occur more rare compared with type 1A and 1B. There are stages of hereditary hemochromatosis. Initially, patient has a just genetic predisposition and has no any symptoms, no clinical, no lab test. If this stage progress up to first, patient has biochemical symptoms. It can be elevated transferrin level, normal ferritin level, and has no symptoms. In stage 2, patient has elevated N-transferrin saturation and ferritin level with no clinical symptoms. And in stage 3 and 4, patient has N-clinical and lab symptoms, and clinics it can be liver cirrhosis and hepatocellular carcinoma and cardiomyopathy, diabetes. In lab test, we see elevated transferrin saturation and level of ferritin. Condition which can present with iron overload, and we should differentiate with hemochromatosis. It can be anemias with dysfunctional erythropoiesis. It's aplastic anemia, hemolytic anemia. It's a spherocytosis, in patient who has long-term hemodialysis, in patient with sickle cell anemia, thalassemia. Another group is chronic liver disease like alcohol liver disease, viral hepatitis B and C, non-alcoholic fatty liver disease, porphyria. Inflammatory disease like rheumatoid arthritis, SLE, malignancies, parenteral iron overload, iron transfusion, hemodialysis, red blood cell transfusion. It's all situation and disease which can lead to iron overload and not connect with hereditary hemochromatosis. I tell as a stages of hemochromatosis can be first asymptomatic, after we can see elevate liver enzymes and elevate level of serum ferritin and transferrin saturation. From clinics, due to this disease is polysymptomatic and many organs can damage. Patient can have fatigue, arthralgias, decreased libido. It can be very common symptoms like diabetes, liver cirrhosis, and abnormal skin pigmentation. At this table, you can see summarized data from endocrine organ, cardiovascular system, gastrointestinal symptoms, reproductive, endocrine, skin change in patient who has hemochromatosis. It means that many doctors can visualize such patient and should suspect hemochromatosis in patient with such symptoms. For diagnosing hemochromatosis, we use first of all increase in ferritin level greater than 300 nanogram per milliliter for male and higher than 200 nanogram per milliliter for women. Saturation, transferrin saturation greater than 45% is again one of the diagnostic criteria hemochromatosis. After we do diagnostic test for stages of liver disease, because in patient who has hemochromatosis, it can be normal liver, it can be symptom of hepatitis, symptom of fibrosis and liver cirrhosis. That's why we do any elastography examination of liver for diagnosing stages of fibrosis. And in any cases we do liver biopsy because it's a gold standard for diagnosing, and we can evaluate and fibrosis and hemochromatosis and other diagnosis in patient. For diagnosing test is very important for confirmed diagnosis hemochromatosis, and I told that mutation of gene HFE and mutation C282Y is very common. Very important that we do screening for a person who is more elder than 18 years old, because in more younger patient we don't see clinical manifestation of hemochromatosis. For diagnosing we use all these tests: hepatic iron index, transferrin saturation, ferritin level, iron level and genetic test. But you can see that no one test has a 100% sensitivity and specificity. That's why we should take into account all methods together, summarize all data, and after we decide about hemochromatosis. About treatment, of course, first line treatment is a phlebotomy for patient, and we control level of ferritin. It should be around 50 nanogram per milliliter. In patient who has a end stage of liver disease, liver cirrhosis, we consider liver transplantation. Phlebotomy we do in patient and who has a high elevated level of ferritin or transferrin saturation. We control it. Of course, phlebotomy has many positive effects like improve heart function, reduce abnormal skin pigmentation, decrease risk of liver complication, but these methods of treatment has side effects like phlebitis, hematoma, infection, neurovascular damage. That's why we should use it in strong control. The American College of Gastroenterology recommend weekly removal of 500 milliliter of blood under control of serum ferritin level. And when this goal of ferritin achieved, then patient should undergo lifelong phlebotomy 3 or 4 times per year with monitoring of ferritin level every 6 months. Another alternative methods of treatment patient with hemochromatosis is erythrocytoapheresis. Is a method when we remove red blood cells and return the other blood components to patient, but this method treatment is limited by its availability and cost. Another method is a chelation, and when we use medications to bind serum iron. It's not first line treatment patient due to side effects like as neurotoxicity, neutropenia, agranulocytosis, increase creatinine level, liver enzymes, but in patient who has uncontrolled level of ferritin after phlebotomy, we think about second line treatment. Necessary to note that patient with hemochromatosis should be vaccinated against hepatitis A and B. The general recommendation for patient with hemochromatosis is a lifestyle change like decrease alcohol consumption. It's a dietary recommendation. We should treat another complication like organ damage, diabetes, according to standard protocol, cardiomyopathy, hormonal change, endocrine diseases, liver disease symptomatically, and think about liver transplantation in case of late diagnosis of hemochromatosis. Thank you for attention.